Thank you, Bill, Paul. That was a wonderful talk. I have some comments later about that because I agree. I agree 99.9% with everything you said. All right, I could skip this talk because the panel discussion before the break almost covered a lot of these things. So I can go fast, which is good. But it's really very important. Now that we're seeing so many elderly patients with AS and considering TAVRs versus surgical SAVR, this is very important. So obviously we've stressing on what Paul just said. First step we'll have to do is assess wall severity. And in AS, obviously, mild, moderate, and severe are very important. And we always start by the gradient because that's what the ventricle feels, is the gradient. And we all use the 4V square equation. And we all should know that that equation comes from an equation that nobody in this room would want to remember. Because the first component we all can remember, okay, is basically this component here becomes 4 when all the units are corrected. And then this is the velocity of the jet across the valve square minus the proximal velocity prior to the valve also square, okay? These components mathematically are huge, but they're very important. They're flow acceleration and viscous friction. Well, in normal biological states, they are so small that we get kind of, let's get rid of them. So we ignore them. And most of the time, this velocity in the LV outflow is 1 or less. So square of 1 is 1. Let's get rid of it. And that's how we got this. So we got an incredibly easy equation that even I can remember. But we need to remember that because it was simplified, there are potential problems. One of them being very important is what happens is this proximal velocity in the LVOT is not 1, but it's 1.5, 1.8, even 2. Then it's not easy to ignore it because there'll be errors. In addition, obviously, if you had a stenosis that is not discrete, it would also have errors. So I see reports of people that have perfectly normal aortic valves, and they still give a continuity equation valve area. That's rubbish. It's trash. If you don't have a discrete stenosis, no longer you have a 4V square that you can use. Because it's based on the concept going from a big space to a tiny little hole. The slide Paul showed with the hose, pinching the hose. That's the basis. So if you have a decent orifice, you no longer can do. You're going to get these gradients reported. They don't exist in the cath lab. All right, case in part, very important. This case actually hit us in the butt, as we say, a few months ago. This was a 90-year-old lady that had a lot of heart failure symptoms and had AS, okay? That's her CW. Now, I think this was overtraced by the sonographer, but if we don't ignore that, still, we come around here, easily we are at 4 or higher, and the reporting gradient was 52. I would have probably dropped it down to 45 with a little better tracing, but still, it was significant. And of course, the valve area was also tight. So this lady, after a lot of discussion, went to TAVR. And in the cath lab, that's what they found. And the anatomic valve area was close to 0.9, which matched the cath. And you can see there, you can see by yourself, that's not severe AS. Okay, whoops, what happened? We're supposed to have a great lab. These things can never happen in our lab, right? Well, look at this study. Very interesting study. Hyperdynamic heart, she has MAC, and she has kind of a narrow, very small, narrow LVOT. And look at the color. There's a tunnel here. And look at the PISA. So the PISA starts forming acceleration right here. And all of this is a tunnel area of acceleration. And the congenital pediatricians, they have known this very well because in a lot of pediatric diseases, you have this type of tunnel, type of narrowings. 4V square goes to hell, okay? Look at the LVOT velocity, over 1.5. So these things do happen, and if you don't have that, pay attention to details, you can get in trouble. So this patient obviously was treated medically because she had a lot of diastolic heart failure, and she did have some AS, but not to the point that she needed something. So beware of narrow LVOTs and high velocities will happen in dynamic LV. Big chance for overestimation of gradients. This is what I show you is not that uncommon. This is less common. When you have two discrete stenoses close to each other, where in our environment is either a membrane in the LVOT or hypertrophic cardiomyopathy. This is a membrane. You can see very nicely the pizza right there, forming right in that area where the valve is way down here. So the membrane sits here. So you have a nice tracing, and you have a gradient, but it's a combined gradient. That's a gradient of all the stenoses, both discrete stenoses together. Look at the valve itself, doesn't really look that bad. And interesting in this discussion is what to do with the aortic valve if you're going to repair the membrane. So this is times when you probably need a better anatomic assessment of the valve, because here you just have a combined gradient. And of course, this one we see a little bit more often, which is hypertrophic cardiomyopathy, very nice SAM, so, basically dynamic stenosis, but also AS. So now you have this combination of gradients. In both situations, really, it pays off to get an anatomic valve area. Either well-done TEE, that has its little problems too we could discuss. Today in our lab, what we do is we do CMR in a case like this, and we've had a few nice examples of that. Because you're going to have to make some decisions as to what to do. If it's hypertrophic cardiomyopathy, it may not be as complicated, but if it's a membrane, you definitely have to make some decisions. And actually, most of the time, you end up having to take care of both because of other issues that occur with the aortic valve when you have membranes. All right. Most important thing that we have on a day-to-day basis is aligning parallel to the AS jet. That's the big one. And we all teach about using multiple windows, but for some reason, sonographers, they just love that apical. And now nobody wants to learn how to do a pit-off. So we have situations where sometimes you can have a real problem because the best alignment may not be apical. This patient, this is the best they could get from the apical window, okay? So what's the velocity? 2 or maybe 3? But look at this tracing. See how rounded that is? Look what happened when they went to a right parasternal. 4.7. Very rounded. Very nice. And this rounding of the contour is something worth keeping in mind. The worse the AS, the longer the acceleration time, and the more rounded it looks. And that can really help you. Another case, bad EF, stone of an aortic valve, even 2.2 meters per second, but look how rounded it is. This one is about 3 meters per second. Look how rounded it is. Should we give dobutamine? We could, but actually we were lucky. We didn't have to give dobutamine because with a pause, it went almost to 4. So you see here, 3, 2, 4 almost, but all of them rounded. So that rounded contour can really be helpful. And then at times, you get that. All right? So what do you do in that situation? Well, today, you spend an extra $100, and you grab a little vial of contrast, and quite often you can get that, okay, and save the day. So contrast can be extremely helpful when you have tried everything and you don't get much of anything. All right, this happens very rarely, but it still can happen. If you're going from a parasternal, particularly suprasternal window, you can hit an MR jet, and it can look like a yes, okay? It should never cause a problem. Why? If what you see from the suprasternal is way off from what you're getting from other windows, do something very simple. Go to your LVOT velocity, measure the ejection time. If you have another AS jet from another window, measure the ejection time, and then go to the MR and measure the so-called ejection time, and this one will be way longer, okay? So in reality, if you pay attention to little details, it shouldn't happen, but it has happened. And patients have been sent to surgery with a bad calculation from a jet that was MR. Now, how reproducible are we? This stuff has been done. Look at the dates. These are all dates. And clearly, this was a very important study. 2 centers. 2 centers. So it was like 2 sonographers, 2 centers, 2 different machines. Yet, you can see very nice relation, okay, with the jet itself, okay? So with some element of expertise, you can usually hit the jet fairly well. And we see that in our own lab. When people come back, we're very close usually in that jet velocity. But the valve areas, they're all over the place. Why? because valve area is, as you heard in the earlier talks, using the LVOT diameter to calculate stroke volume divided by the TVI of the AS jet. And look at, when they look at LVOT diameters, centers A versus center B, and the variability of the valve areas all over the place. However, if they say, you know what, forget it, let's give everybody a 2. Because the velocities were so reproducible, well, the valve area became very reproducible because they artificially fixed the LVOT at 2. I'm not saying that we should do that. This was just a proof of concept that the biggest problem we all have with the valve area is with the LVOT diameter. And sometimes with the LVOT velocities too, but mostly LVOT diameter. So whenever possible, have the same lab, the same sonographer do the study. Whenever possible. It's not always possible. But what is possible is to look at an old report. And if you have a nice study from the old report, use that LVOT diameter. Don't reinvent. Because every time they come in, one guy gave 1.8, another person gave 2.1, another person gave 2.2, another one went at 1.9, and the values are all over the place. Okay? So at least try to accept one number that you feel was accurate. And unless there is a dramatic change in structural anatomy, which rarely happens in these people, stick with that number. Because then, in a way, you're fixing it and keeping a better control. This is a real problem in day-to-day practice. Then the other problem that sometimes we get when people get referred to us is this magic creation by people in a room smoking cigars that they decided that 1 or less was critical. We tend to use more 0.7, they use 0.6 per meter square. And of course, this is actually, next slide is taken from the editorial that Dr. Sugby wrote when they were in a situation of low flow, normal EF AS, critical AS. This patient has a valve area of 0.95, it would be critical. Look at the jet, early peaking, 3 meters, mean greater than 20-something, asymptomatic in 06. Comes back, same story, 0.8. Comes back in 08, now it's 4 meters, okay? So now, from here on, we had the real McCoy, okay? And eventually he did get surgery. Should he have had surgery here? Total asymptomatic, happy? So this value of 1 can be a real problem. And all AVAs of 1 or less are not created equal because of all the issues that have been looked at, flow dynamics, and so on. We know about people with bad EF. You get a valve area of 0.7, you give the butamine, it jumps to 1 because the stroke volume jumped, and the patients had moderate AS, and with the output increasing, the valve stretched a little more. Some do, some don't. Others, you give the butamine, and the gradient jumps to 40, and the valve area stays at 0.7, 0.8. Because there's a lot of anatomy variabilities between some valves that can stretch a little bit. Actually, Steve Little has done some beautiful work with that, with 3D printing. I don't know if you're going to talk about that in the meeting, but this week he had a beautiful presentation on that. And others are very rigid, and they will stretch less when you change outputs. So all these things are very, very dynamic. And at the end of the day, it's a patient. It's not the valve area that you operate on. It's a patient with the symptoms, with the gradients. Somebody has combined AS, AI. They may have a valve area of 1.7, but they have a gradient of 60. Who cares about the 1.7 valve area? They have a huge flow through the valve because of the combined lesion. You're still going to do something about it. So don't live or die by valve area. However, it's still a very important parameter that we incorporate in our decision making. So in summary, pay attention to the contour of the AS velocity. That's one of the most important things that can get you out of trouble. Always search for the highest velocity, multiple windows. Insist that at least one sonographer in your lab have not lost the art of a pit-off. And contrast can help. The Bernoulli 4V square, it's great 90% of the time, 99% of the time, but it can get you in trouble, particularly when you have these very high LVOT velocities. CW cannot distinguish gradients between serial obstructions, so you end up with one combined gradient, and that's one time that an atomic valve area can be very helpful. And the reproducibility is always best with the gradient, very bad with the LVOT, and therefore consider using the same diameter that you feel comfortable from one of the studies that is well done on your serial assessment. Thank you very much.